take it away.
All righty. Good afternoon, everyone. Let's see. So we'll go on here. Today I'll be discussing orbital pathology, particularly must-know diagnoses in the pediatric orbit. And so I tried to focus on things that really distinguish the pediatric orbit from the adult orbit, specifically for any residents or fellows that are on this conference that are wanting to know more about pediatric diagnoses. I do have a QR code at the top right here that actually, if anyone wants to go ahead and scan this, there will be a couple of POL-EV questions throughout the talk, mostly in the middle and at the end. So if you don't have a chance to scan it now, then we can go ahead and I'll show this again a little bit later. So I'll give people like 10 seconds to maybe to scan this. I guess I should have put that up before. All right, so again, if you didn't catch it now, we'll have it again later. So a brief outline for this talk. First, I'm going to review some important orbital anatomy that's key to understanding for when you're reviewing certain cases. And then I'm going to break down the lecture by topic. So we'll discuss orbital masses, followed by congenital developmental abnormalities, traumatic injuries to the orbit, and then infectious and inflammatory conditions within the orbit. So looking at anatomy first, this is a coronal T1 high-resolution image of the orbits, and here's an axial T1 high-resolution image of the orbits. And when we're looking at the orbit, you can break up the intraorbital compartments into intraconal, which is within this myofascial cone here, and then extraconal beyond that myofascial cone. Intraconally, you actually have the optic nerve sheath, which you can see here, which has the dura, the CSF, and the optic nerve. And then you're highlighted here in purple are the extraocular muscles with medial rectus, the lateral rectus, superior and inferior, and then you have the superior oblique here as well in the corner. So let's zoom up into the globe because I think it's important to know the globe anatomy well as well when you're looking at these cases. So the anterior chamber is this section of the globe with some aqueous humor that goes from the cornea to the iris. The posterior chamber is actually from involving the iris to the lens. And I think that this is commonly kind of misnamed or the nomenclature can kind of be a little bit confusing because together the anterior chamber and the posterior chamber make up the anterior segment of the globe. And then the vitreous body actually makes up the posterior segment of the globe. So within the anterior segment, you actually have the anterior and posterior chamber containing aqueous humor, and then the vitreous body is actually the posterior segment of the globe. Then you have laterally the ciliary body and suspensory ligaments, the lens, and then if we look at the peripheral margin of the globe here, the bright line that you see here is going to be your choroid. The dark line is the sclera, and then superficial to the choroid here is actually the retina. So we'll keep those structures in mind. The osseous anatomy of the globe is complex in that there are multiple bones actually forming the globe here. You can see them listed here, but you have the frontal zygomatics, sphenoid bones, maxillary bone. And it's important to understand this complex anatomy and know that there are several fissures that are also, and canals that are also within the orbit to consider. So here you can see the optic canal, which contains cranial nerve 2 or the optic nerve, the superior orbital fissure, which has cranial nerves 3, 4, V1, and 6. And then taking a swing here, you can also see the inferior orbital fissure. So keep these things in mind. And then also here is the infraorbital foramen as well. So let's start with orbital masses. So going forward, I'm going to group the differential diagnosis by location to help us out. So first, we'll start with globe abnormalities. So retinoblastoma is one of the tumors that you will see in children, most commonly presenting before the age of 2. And the most common presentation that that will have the patient present is actually leukocoria. So it's a white reflex of the eye. The parents might notice it when taking a photo, or just notice the pupil looks wider than it normally does. And then these tumors will come to attention. It's related to an RB1 tumor suppressor gene, so it can be a germline mutation or it can be sporadic. And most oftentimes, prior to the MRI examination, the patients will be coming with a diagnosis of retinoblastoma based upon ophthalmologic exam and clinical history. So our job when we're evaluating the MRI examination is really to determine the extent of the tumor, and whether or not there's extraocular invasion, whether there's invasion of the optic nerve sheath or optic nerve itself, and that's going to guide management for these cases. So here you have a typical appearance of a retinoblastoma. You can see within the right posterior globe vitreous body, there's an enhancing lesion that shows reduced diffusivity and T2 hypointensity. And if we look at the margins of the globe here, you can see that there's some, that normal choroidal enhancement is that T1 hyperintense enhancement here. And sometimes, one of the things we want to look for is choroidal involvement, and it can be difficult when the tumor is right up against that choroid. But we'll look at some examples on the next slide. Another thing that you want to actually look for is whether or not there's invasion of the lamina cribosa before the optic nerve here. So I put a couple of stars next to key clinical things that I think are takeaway points for the talk, so just pay attention to those. But in particular, these cases for retinoblastoma, you want to evaluate for the following. So optic nerve involvement. Here on the top left image, you can see that there's an enhancing mass in this right globe, which appears large, expanded. And if we look at the optic nerve here, posteriorly to the lamina cribosa, where the optic nerve head inserts, you can see that there's enhancement of the optic nerve, enlargement of the optic nerve, telling us that their optic nerve is involved. Sometimes you can actually get a little bit of optic nerve enhancement just at the optic nerve head if there's elevated intracranial pressure. Other things to consider is whether there's scleral invasion or extraocular retinoblastoma. So here you can actually see that dark line of the sclera around the globe. And anteriorly, there's actually breach of that line, so there is scleral invasion here. Anterior chamber involvement, which is rare. And here you have actually hemorrhage within the anterior chamber and displacement of the lens posteriorly. And then in this bottom picture here, you can actually see that there's also a retinal detachment with a hemorrhage fluid level as well. So retinal hemorrhage and detachment. So these are different kind of points that you want to evaluate for that will dictate the management in these patients. So extraocular involvement, choroidal invasion, anterior chamber involvement as well. And this is a paper actually that I found helpful that actually goes through a lot of these different findings for those that are interested. Another finding on this particular slide here, when you're looking at these cases, you always want to look for contralateral disease. So you can see in this left globe here that there is actually another tumor here in the left orbit as well. So this patient has bilateral retinoblastoma. So with the RB1 tumor mutation, in addition to these orbital findings and the optic pathway findings here, or I shouldn't say globe findings, you want to look for contralateral disease. And then you also want to look for additional sites of tumor predisposition. So these patients can get osteosarcomas, soft tissue sarcomas, melanomas, and then, brain and nasal cavity tumors. So this is an example of a patient who had a history of retinoblastoma. And you can see here that there's a T2 hypointense enhancing mass in the left paranasal sinuses, which is concerning, which was a sarcoma. Now, when we're thinking about patients that present with leukocoria, retinoblastoma is not the only pathology that actually presents with leukocoria. So these are some additional things that we'll talk about, but you can have retinal detachment, retinopathy at prematurity, colobomas, persistent fetal vasculature, Coates disease. So we'll go into some of these further, but some of them are described as mimics of retinoblastoma. And this is an example of a case of retinal dysplasia, where you can see that there are abnormal fibrous bands within the vitreous body here within the globe. So when you have a patient who has an enhancing globe mass, but they're a little bit older, something that you can consider is actually a choroidal melanoma. So in this case, you actually have an enhancing lesion within the left globe. These are rare. So I think choroidal melanomas in children represent less than 1% of uveal melanoma. but they can happen, particularly in adolescents. And they don't have to have intrinsic T1 hyperintensity on MRI exam. So here again, you have this enhancing lesion with some reduced diffusivity, and this ended up being choroidal melanoma. Let's see. Now, in imaging pediatric patients, a lot of patients might have syndromic disorders or additional findings where the orbital findings aren't exactly the purpose of the scan. So here on the bottom left, you can see typical findings of Sturge-Weber. So if we look at the posterior, the parietal lobe here and the posterior temporal lobe, you can see that there's pial angiomatosis, some brain parenchymal atrophy, some enlargement of the choroid plexus on the side, all findings that you would typically see with Sturge-Weber. And in looking at this patient on some of the initial imaging sequences, you can see that if we look at the right globe, that there's this abnormal soft tissue appearance along the posterior globe here, which on initial review, you're thinking, oh, could this be, it has this V-shaped appearance, could this be a retinal detachment? As the exam went on, you can see that there's some intrinsic, there's some T1 ISO intensity here. And on post-contrast, it actually enhances. And so these patients can actually have choroidal hemangiomas as part of their diagnosis of Sturge-Weber syndrome. And this had been kind of progressing over time. And I remember, so I had called the ophthalmologist to kind of discuss with them whether or not this was compatible with their ophthalmologic exam. And indeed, actually, over serial ultrasound exams, it did look like this choroidal hemangioma was increasing in size. So here's an ultrasound image showing that choroidal hemangioma. So these are typically unilateral to intracranial findings and can be treated with observation and phototherapy. But this is my reminder to always assess the orbits and the globes in these systemic diseases, and also to discuss the findings with clinicians. I thought it was really helpful to discuss with ophthalmologists that what we're seeing is similar to what they're seeing. So in that similar vein, another entity that we can actually see is retinal astrocytic hamartomas. This is a case of tuberous sclerosis. You can see multiple cortical and subcortical tubers throughout the brain parenchyma, as well as subependymal nodules here around the ventricular margins. And if we look at the globe, you can see that there is a nodular area of signal along the posterior retina here, T2 hypointense. And these are typically retinal astrocytic hamartomas. It's a benign glial tumor, and they're identified mostly in patients with tuberous sclerosis, but they can be sporadic. And usually they're asymptomatic and without growth. And this is a final case of kind of thinking about systemic diseases and looking at the orbits. So here on the initial scan, we have an axial T2 fat-saturated sequence, and then axial T1 post-contrast sequence. And you can see that basically there's abnormal signal within the anterior chamber here and the periorbital soft tissues. And in this case, the history was that the patient had leukemia, had sudden onset of hyphema and blood in the globe. Ophthalmology was trying to do an exam under sedation, but unfortunately, because of all the hemorrhage, they couldn't really see what was going on. They didn't see a large mass, but couldn't really make out any specific leukemic infiltrates. So they decided to get this MRI exam. And if you look at the post-contrast images, you can see that there is enhancement along the iris and the ciliary bodies here, and along the periorbital soft tissues as well. 5 days later, the scan was repeated. Again, you can see that there is this anterior hemorrhage within the anterior chamber here. And then the enhancement persists in that left globe, but now there's new enhancement of the iris and the ciliary bodies in the right globe. And so this was compatible with leukemic infiltration of the anterior segment here in both globes. Kind of fast forwarding 2 months later, you can see that the leukemic infiltration actually is decreased. You have decreased enhancement of the periorbital soft tissues and of the iris and the ciliary bodies. But when we look at the left globe, it doesn't look normal. So when we started out, the left globe and the right globe were same size. Now we have microphthalmia, or a small globe on the left. And if you look closely, there's a very thin line here. That's actually the margin of the choroid. and some hyperenhancement here. So again, this is a case where I discussed with ophthalmologists. They actually, I was concerned here that there could be like a choroidal detachment, given this that there was this little linear line here. Indeed, that is what they saw on clinical examination as well. And unfortunately, this is poor prognosis in this eye, and this eye will probably go on to develop phthisis bulbi as well. Okay, so let's move on from the globe. We'll go to the optic nerve sheath now. So when we're assessing the optic nerve sheath, one of the more common tumors in pediatrics that we'll see is an optic pathway glioma. You can see an optic pathway glioma in about 15 to 20% of patients that have NF1, although optic pathway gliomas can also be sporadic. When they are sporadic, they more commonly involve the chiasm than in patients with NF1. NF1, you predominantly see intraorbital, you can see more involvement of the intraorbital segments of the optic nerves. On T2 exam, you can see that this optic nerve here is expanded. They often have cystic components, and the enhancement pattern can be variable. And enhancement pattern just generally doesn't dictate treatment in these lesions. It can fluctuate. Typically, the pathology in these cases is low-grade pilocytic astrocytoma. And initially, these patients can present with worsening vision or proptosis or even hypothalamic dysfunction, depending on the location of the tumor. Okay, let's see. Something else to keep in mind. So the typical appearance of an optic pathway glioma is that orbital enlargement and expansion with increased T2 signal enhancement. But you can actually get breach of the pia, where you actually have tumoral infiltration of the pia into the subarachnoid space, which gives you this perineural arachnoid gliomatosis. So here you actually have enlargement of the optic nerve, as well as involvement of the subarachnoid space surrounding the optic nerve. Okay, so now let's move on to intraconal and extraconal lesions. So rhabdomyosarcoma is one of the soft tissue diagnoses that you'll see in the intraorbital compartment. The mean diagnosis of is about 6 to 8 years of age. And these can be broken down to alveolar versus embryonal subtypes, and they're considered parameningeal if there's bony orbit or optic nerve invasion. Typically, these lesions will show avid enhancement, and the key thing is on diffusion weighted images that you have restricted diffusion, suggesting hypercellularity in this tumor. Oftentimes, these can be confused with hemangiomas, which I'll show. And I think that the key here is that diffusion is your friend to show that the tumor is actually hypercellular. So let's contrast that to an orbital infantile hemangioma. This one is in the preseptal soft tissues. You can see, again, similar appearance. It's a little bit T2 hyperintense. There are some flavoids within it. But in addition to the diffusion, the clinical history is going to be key in these patients. So they should, clinically, they usually present with a soft mass that has bluish discoloration. And then the other thing to keep in mind is that these should follow the correct growth pattern if they're able to be assessed on clinical exam. So typically there's a proliferative phase for about a year, followed by involution, which this lesion did show. Another soft tissue lesion that you can have in the globe is a lymphatic malformation or a venolymphatic malformation. Here within the right globe, you can see that there's a cystic lesion with a fluid hemorrhage level, suggestive of a lymphatic malformation. They can be microcystic with small cysts or macrocystic with larger cysts. And it's important because if these patients present acutely, sometimes they can have pain or proptosis. There are a couple of different complications that can cause a patient to present. So one of them being intralesional hemorrhage, which is what we see here. The other thing can be thrombosis, or you can actually also have superimposed infection as well. And if you're looking at this image, you can probably wondering, like, why is she pointing to the right globe? The left globe is also abnormal. So we do have involvement of the left globe here as well, with a venolymphatic malformation with some enhancing low flow venous components as well. Plexiform neurofibroma, we've discussed optic pathway gliomas. So patients with NF can get optic pathway gliomas, but also plexiform neurofibromas. Typically, they are a soft tissue lesion that can be intraconal or extraconal. Here we have an extraconal T2 lesion, T2 hyperintense lesion with some enhancement. They can be multispatial and can present with a variety of symptoms depending on location, but and management also will depend on what the symptoms are. But in addition, on this particular image here, you can see that beyond the plexiform neurofibroma, this patient has additional findings of NF, which is that there is sphenoid wing dysplasia here. And then if we look at the globe, actually, and compare the right globe to the left globe, it looks like the right globe is a little bit bigger. So there's bufophthalmos, which is enlargement of the globe, which is different than macrophthalmos in that you have enlargement of both the anterior chamber here, basically the anterior segment and the posterior segment. So you can also see this finding with neurofibromatosis type 1. And interestingly, you can actually see choroidal thickening in cases of NF1. So this is a patient who has some choroidal thickening along the margins of the globe here. And this is actually not the MRI characteristics, but on clinical ophthalmologic exam, they've seen some choroidal abnormalities that are actually now included in the classification or included in a diagnostic criteria for NF1. So it's interesting to sort of pay attention to the choroid in these cases too. You might see some choroidal enhancement. All right, now we'll move on to the bony orbit. So the first diagnosis I'll discuss is Langerhans cell histiocytosis. With Langerhans cell histiocytosis, you can have usually unilateral or unifocal disease versus multifocal disease. And usually the median diagnosis is 2 years of age, and involvement of the supratemporal orbit is common. In this particular case, you see here a T2 well-demarcated narrow zone of transition lesion that's a little bit T2 hyperintense and avidly enhancing. It has extradural extension of tumor as well as intraorbital extension of tumor. And what's interesting is that on these, so these will have a typical punched out appearance, which we'll see as well on CT, but earlier on in CT, they can also demonstrate some periosteal reaction, which can confuse a picture and look a little bit more aggressive than the typical punched out lesion that is described. Another entity to consider when you're looking at the bony orbit is a neuroblastoma metastasis. It's thought that there's that it has a higher predisposition for neurocrest cell metastasis in this location. These patients can present with these periorbital ecchymoses, and actually about 30% of patients with neuroblastoma actually have orbital metastasis. So you can see here this, again, there's intraconal or intraorbital soft tissue extension of tumor with enhancement and reduced diffusivity, suggesting really highly cellular component of tumor involving that lateral orbital wall with soft tissue extension into the orbit. And the last osseous abnormality I'll show is this dermoid epidermoid. So these occur secondary to rests of endoderm located at the orbital sutures, so commonly at the frontozygomatic suture. Typically, they're T2 hyperintense. They can have variable signal characteristics on T1 depending on what the internal components are, and then typically show reduced diffusivity and thin peripheral enhancement. So our job when we're looking at these MRI examination is diagnosis, but also evaluate for orbital extension. So the surgeons and the ophthalmologists will want to know exactly what compartments these dermoids or epidermoids are involving to dictate their management. Alrighty, so let's move on to some congenital and developmental abnormalities. So again, we'll start with the globe. This is sort of morning glory disc anomaly, typical appearance where you get this funnel-shaped excavation of the optic disc. Basically, when you're looking at thin section imaging or even post-contrast imaging, you kind of see this heaped up soft tissue obliterating the CSF space at the optic nerve head here, which is a typical presentation of a morning glory disc anomaly. These are usually unilateral and sporadic, so not necessarily associated with a congenital condition. However, they are associated with some midline anomalies, such as a persistent craniopharyngeal canal, which we see in this case. They can also have basal cephaloceles, And in this bottom right image here, you can see a nice classic case of a patient with a moyamoya. So you have distal tapering of the ICAs bilaterally, and then loss of flow-related enhancement in the M1 segments of the middle cerebral arteries here. So that's a classic appearance for a moyamoya in a case of a patient with a morning glory disc anomaly. Now we can compare that to a coloboma. So a coloboma is a congenital ocular defect that can happen anywhere along the globe. And you sort of get this focal outpouching here, continuous with the vitreous. And as opposed to morning glory disc, where those cases are more likely sporadic, colobomas are more likely are associated with a number of congenital conditions. So, for example, here, this patient has charge syndrome. You can see there are bilateral colobomas, absence of the lateral semicircular canals, absence of the olfactory bulbs here, for shortened pons as well. Anophthalmia, microphthalmia. So just to show a couple of cases of that. So on the left here, you can see that there's absence of the globe completely. There's some soft tissue within the globe, and overall the orbit is underformed or very small. So this is typical of what you'd see in a case of anophthalmia. This can be related to basically insult or degeneration of the optic vesicle from preventing it from forming, or degeneration after it has formed in utero. Versus microphthalmia, where you have a small globe, sometimes which actually can look normal, have normal appearance, but just be small, but also can be associated with a number of other orbital abnormalities. So for example, here we have a case of persistent fetal vasculature, where you can see the globe is smaller than the contralateral side, which is also abnormal. So with persistent fetal vasculature, you often get this martini glass appearance or triangular shape of the lens with a thin fibrous band extending posteriorly. This is secondary to failure of regression of the hyaloid vasculature by the 8th month of gestational age. Usually it's unilateral, but you can see it bilaterally and syndromically as well. So one of the etiologies or one of the diagnoses that you can see it with is Walker-Warburg syndrome or trisomy 13. If we look at the image here that we have an example of, you can see that there is actually some abnormal appearance of the cortex that's kind of compatible with the cobblestone lissencephaly. So in this case, we actually have a diagnosis of Walker-Warburg with persistent fetal vasculature. Sometimes these ocular abnormalities, the congenital ocular abnormalities like primary hypoplastic vitreous can be confused with retinoblastoma. However, here you have like a microphthalmic appearance versus something in retinoblastoma where you really wouldn't get a microphthalmia. And also a difference in calcification. So with retinoblastoma, as we said on CT, you would have calcifications. In this case, you would not. Retinal detachment is common, and then the goal in these cases is actually to prevent glaucoma. So sometimes they'll actually resect the lens as well to prevent that. So Coats disease is another entity that you can see in kids. It's an exudative retinitis that occurs secondary to defective or leaky retinal vasculature. And so it's usually unilateral, and these patients can also present with leukocoria and strabismus. Importantly, it's not mineralized on CT, and on CT, the exudate can be hyperdense as well. So again, this could be something like a retinoblastoma mimic, but you shouldn't really have calcifications. And sometimes you can have a little bit of optic nerve enhancement if it's associated with glaucoma. The last entity of the globe that I'll just discuss is this ventral-lentil fibrodysplasia or retinopathy of prematurity. And this happens in patients that have extreme low birth weight, so less than 1 or 2 kilograms. It's associated with excess oxygen therapy. So the hyaloid vasculature doesn't regress, and then it kind of disrupts formation of normal retinal vasculature. And so then you get fibrovascular soft tissue leading to vision loss in these babies. And so here's an example of that with this abnormal fibrovascular tissue within the right eye and microphthalmia. These kids can get retinal detachments and sometimes can also have dystrophic mineralization, but with microphthalmia. So this is a case where if you want to just look at the globe, don't look at the globe itself, look at the orbit. What is exactly wrong with the orbits here? So I'll give you a second to take a look at it. And then we'll go on. This will be our first poll everywhere question. Oops, I don't know what just happened there. Okay, so the question is, what is the abnormality? I'm not sure if people were able to scan that before, but you can scan this and join the poll everywhere. Let's see if we get any responses, and then let's see. All right. No responses. So maybe people, I'm not sure if people were able to scan this, but I'll put it up in a sec again here in case anyone wants to scan this. And then we'll move on. So the answer here is actually hypertelorism. And let's see. Sorry, this is kind of freezing my system here. Okay. So the answer here is actually hypertelorism. So this is just a reminder to look at the bony orbits themselves for abnormality. So in those prior images that I showed, the globes were abnormal, but if we look here, there's exorbitism and hypertelorism. So with hypertelorism, there are exact measurements, but generally speaking, when I'm looking at the globes, you want to make sure that you can maybe fit like a third globe between the orbits of between these other two globes. So if I were to take one of these globes and put it in the middle here, you'd see that there's some extra space between those two globes. Also, if you draw a line, an interzygomatic line here, the orbit should actually be about 30% or 50% behind that line. And so here, actually, the globe is anterior to that. So you have these shallow orbits with hypertelorism, exorbitism. If we look at the remainder of the images here, you have bicoronal synostosis, some soft tissue syndactyly, abnormalities of the temporal bones where there's fusion of a lateral semicircular canal in the vestibule, and then also foreshortened anterior cranial fossa and midface hypoplasia. So the question here is, what is the diagnosis? I think I'll give people a chance to think about it. I'm not sure if the response system is actually working, but we'll see. There we go. We've got some people. All right. So 50% for Apert syndrome, 50% for Noonan syndrome. The correct answer is Apert syndrome. So this is a case of craniosynostosis. So with Apert syndrome, if we go back to those other images here, these are some typical findings. The key here is actually the soft tissue syndactyly and the bicoronal synostosis. You get this towering shape of the calvarium. And those are all pretty typical features. These are associated with fibroblastic growth factor receptor mutations, and they can have additional palatal abnormalities and vertebral body abnormalities. All right, so let's move on to trauma. There's a couple of particular traumatic diagnoses that I thought would be good to review in the pediatric orbit. So first is retinal hemorrhage. We had a great lecture by Dr. Sarma regarding abusive head trauma, but I wanted to highlight, when we're looking at these images, really want to highlight that we should be looking for retinal hemorrhages. So there's abnormal T2 hypointensity along the posterior globes here. If we look at this axial T2 image, you can see that there's subdural hemorrhages as well. And so although we are not, all of these patients are getting ophthalmologic exams to evaluate for retinal hemorrhages, we can pick up on certain of these findings. And so I think it's important to remember that and to look at the globes in cases of abusive head trauma. These hemorrhages typically on ophthalmologic exam have an appearance that's described as too numerous to count and multi-layered as being specific. So this is just my reminder to not forget to look at the globes in those particular cases. Moving on to some orbital injuries. So bony injuries, you actually have traumatic orbital blowout fracture. Now, blowout fracture has kind of become like an all-encompassing like general term for orbital fractures, but here we have an inferior floor fracture. And you can see in the left maxillary sinus that there's some hemorrhage. and that the left orbital floor is depressed and it kind of goes through that inferior orbital fissure. The important thing here is actually that you want to evaluate for herniation of orbital contents. And the reason I show this is actually in kids, this fracture happens more like a green stick fracture. So kids are more likely to get entrapment than an adult who has sort of like a comminuted fracture of the inferior orbital floor. So you want to make sure you're looking for herniation of orbital contents, any entrapment of the extraocular muscles, although that would be an exam, a diagnosis also based on clinical exam, and then any post-septal hematoma or compartment syndrome. And these patients will present with diplopia, enophthalmos, and hyposthesia as well. Here is an example of an open globe injury, which is an ocular emergency. So you can see that there's microphthalmia with lens displacement. This child who has experienced a dog bite to the orbit. You can see that there's periorbital soft tissue swelling. So this is considered an open globe injury or laceration versus something that is also a globe injury, but related to blunt trauma, as we have in this case. So there's blood in this globe here with microphthalmia as well. So this is actually considered a globe rupture, meaning that the pressure was from in to out. So it happened from blunt trauma and increased ocular pressure versus an open globe injury from a laceration. Call this the trip and fall. So here we actually have, this is a foreign body. This is actually a portion of a tree branch that breached the fovea ethmoidalis and the herbiform plate here with you can partially see a contusion here. So always look for foreign bodies in these injuries. And then this is an interesting case of a patient who kind of fell on a pencil. The pencil went into the orbit, they pulled it out, didn't think it was too much of a trauma, but then had blurry vision. And you can see that there's periorbital soft tissue swelling, and then there's abnormal signal within the medial rectus muscle here, as well as the optic nerve. So the patient actually had a traumatic optic neuropathy related to trauma from the pencil. And what's interesting is that when you look at the CT examination, look back, there are a couple of foci of intraorbital air within the intraclonal space, and there's a couple of studies reviewing imaging findings in traumatic optic neuropathy, and they do say that if in the presence of orbital injury, if you see intraclonal air, that can be a clue if the patient's having optic nerve symptoms or vision loss, that there could be traumatic optic neuropathy to get an MRI examination. The final trauma that I'll discuss is a cavernous carotid fistula. So in this particular case, you have a direct cavernous carotid fistula, which is usually a hole from the cavernous sinus directly to the ICA. And then an indirect would be via tiny meningeal branches of the ICA. But here you can see that there's a really dilated superior ophthalmic vein, dilated cavernous sinuses bilaterally, proptosis and orbital edema, and this was related to a skull base fracture, and here's the angiogram of that as well. These patients can develop pretty quickly if it's a direct cavernous carotid fistula. If it's indirect, the symptoms can be a little bit more progressive over time. Clinical features can include proptosis and orbital pain in the setting of prior trauma. So something, if you have a patient coming in with proptosis and trauma, make sure to look for these findings. Alrighty, then we'll move on to infectious inflammatory. So we have orbital cellulitis. So in kids, orbital cellulitis is most likely related to an infection of the sinuses. It can be post-septal infection secondary to purulent sinusitis in the ethmoid air cells. So here you see that there's opacification of the ethmoidal air cells. If we look at the bone windows, it's always important to scrutinize the bone windows. You can see that there are areas of dehiscence along the lamina propria. And then there's abnormal inflammatory soft tissue within the left orbit with orbital proptosis, globe proptosis here, and likely a small thin subperiosteal abscess. So these complicated sinusitis cases can present with orbital cellulitis. And there are a number of other complications that you want to look for, which include superior ophthalmic vein thrombosis, cavernous sinus thrombosis, and epidural abscess. So I'll show some of these here. This is a case of a child who had complicated sinusitis. You can see that there are postoperative changes here, but there is a right intraorbital abscess with peripheral enhancement, T2 hyperintensity, and there's some reduced diffusivity as well. And this child also developed a cavernous sinus thrombosis. So within the right cavernous sinus, you can see that it's expanded. There's a filling defect here as well. And then these children can also, if there's extensive involvement, develop an arteritis. So here we have an irregular ICAs with narrowing and irregularity in the setting of an arteritis secondary to infection. Another entity just think of in terms of infection is dacrocystitis. So here we have, although adults can get dacrocystitis, it's more common in children when they can have dacrocystocele secondary to stenosis of the distal nasolacrimal duct. And so here you get this sort of cystic appearance of the left nasolacrimal duct with surrounding enhancement, surrounding fat stranding and enhancement. So this is in the setting of a dacrocystitis. So moving toward the optic nerve sheath, we have optic neuritis. So this typically presents with vision loss and pain with movement. You can see that there's T2 prolongation in the left optic nerve and enhancement as well, which is asymmetric, nicely seen in the coronal images. And these can be inflammatory and infectious. When we're considering, inflammatory etiologies, we want to think of MOG, aquaporin 4, and multiple sclerosis. In MOG and aquaporin 4, you're more likely to get bilateral long segment involvement, and something like MS, usually unilateral short segment. The other two things that I think are interesting is that with MOG, if you have, you're more likely to have optic nerve sheath inflammation and less likely to have chiasmatic involvement. So these are some kind of things we're reviewing these optic nerves to think about and sort of sort out with the additional brain findings that you see, depending on whether or not you have additional white matter lesions. The last entity of inflammation I'll talk about is idiopathic orbital inflammation. So this is an exuberant case where you have this T2 hyperintense soft tissue along the left orbit here, periorbital soft tissues, and intraorbital, intracoronal, extracoronal fat. There's enhancement and T2 prolongation. And this can have the appearance of idiopathic orbital inflammation or a lymphoproliferative disorder such as lymphoma. Something that can be helpful in differentiating the two diagnoses would be a diffusion weighted image. Typically, lymphoma would have a lower ADC than you would see on idiopathic orbital inflammation as well. Additional entities could be like IgG4 disease as well. Okay, so I just wanted to put up a couple of comparison cases so that we can kind of hone in on some points from earlier today. So if you take a look at this image on the left, there's a lesion here with some calcification in the globe. On the right, we see some abnormal density within the globe as well. So I guess which image shows the malignant tumor? I think you can just kind of point if you, if you drop down your finger there, you can kind of, or drop down a pointer, you can say pick left or right globe. No, this one's like kind of close. Oh, I think it locked. I can unlock it in case people. Yeah, they're all like left rather, or right rather than left, I guess. So yeah, so this is gonna be your, I'm gonna let the timer go down. That is correct. So this is going to be your retinoblastoma. Again, this is a calcification here with a soft tissue nodule within the globe itself. Again, the calcification clues you in toward retinoblastoma rather than one of the other entities that we talked about. This is Coates disease or the exudative retinitis, where you see some hyperdensity posteriorly, but no calcification. All right, and we have two cases here. So there's one on the left and one on the right. On the left here, you have a well-demarcated kind of a narrow zone of transition lesion, but there's a soft tissue component. On the right, we have this more permeative appearance of a bone with the soft tissue lesion in the right sphenoid wing here. So question here is, what are the diagnoses for the two sets of images? I think this one's you can like type in the diagnosis, but we'll see if anyone types in. So I guess what's on the left and what's on the right? Let's see. All right, so on the left we have LCH. So again, that punched out the lesion with associated soft tissue. Contrast that to what we see in a neuroblastoma, where we have this these irregular bony margins with some periosteal abnormality or reaction and a soft tissue lesion. And the final question here is, okay, so we have this T2 hyperintense lesion, a couple of flow voids avidly enhancing. Here's the diffusion. Doesn't look like there's reduced diffusivity. And I don't know why I keep going back to that, but which is the diagnosis in this particular case? Let's see if anyone can. Yeah. All right, so we've got infantile hemangioma. That is correct. Again, the diffusion is going to be your friend, so there's no reduced diffusivity in that case as well. So these are a couple of different, let's see. That is freezing my screen for some reason. But so in summary, there are distinct entities to consider in the pediatric orbit, whether it's trauma, tumors, congenital disorders, or inflammation. I think one take-home point is that when you're in doubt, speak to a referring clinician. I always learn something from the ophthalmologist when I call them. Consider the anatomic location when thinking of differential diagnosis. These are some important references, I think, if anyone is interested in learning more about the topic. And thank you so much. And thanks for your attention. And thank you, Adam, for arranging this lecture series.
Thank you so much, Joanne. That was incredible. It's very comprehensive. A lot of tough entities that I know definitely have trouble differentiating sometimes with these. It's incredible. If anybody has any questions or comments, feel free to put them in the chat or the question and answer. But we have some great feedback coming in. Beautiful images, great cases. Thank you. Excellent. Yeah, that was incredible, Joanne.
Right. Sorry, I didn't realize my video was off.
Oh,
so this camera like totally disconnected itself, but
oh, it's okay. I didn't want to interrupt you there.
All right. Well, hopefully everyone learned something.
Great talk. See if anybody has any. So question, what is meant by staphyloma?
Yeah, so staphyloma is different. Staphyloma is different than a coloboma. You'll have kind of like a more elongated appearance of the globe. You can kind of see it in myopia rather than a coloboma, which is a more focal area of abnormality in the globe. I wish I had one here to show you when I put it up, but it's the main difference.
Mm-hmm. I just had a question about, so for in abusive head trauma cases, do you guys do specific SWI, like high resolution images to look at the retina, or do you just kind of look on your normal SWI to see if there are hemorrhage there?
No, yeah, we don't get SWI. Well, we get an SWI, not high resolution. I think the one sequence that we do get that's part of the head trauma protocol that's helpful is an axial T2 space that covers the globes. And so I think that's going to be your key image to look for those retinal hemorrhages. And of course, like these patients, like I said, always get ophthalmologic exams anyway. So, but I think it's nice when we can kind of provide, additional information.
Definitely.
Well, great.
Any other questions? I like the ducklings picture.
Oh, this is actually, so I don't know. This is, I don't know if you know the book Make Way for Ducklings.
Yeah.
So there we go.
Yeah.
Yeah. I've recently become a fan.
Read it to my kids a lot. Yeah. Okay. Well, if there's no more questions, yeah, thank you again so much, Joanne, for the incredible talk.
Yeah, thank you.
And then yeah, so we'll see you next month.
Thanks, Adam.
Another talk. Thanks a lot.
Everybody.
Take care.